Good morning.
Good morning.
Please, my name is Samutula Siekuma. I'm an MDC candidate and I'm here to take information from you to help us manage you appropriately. Please, do I have your permission?
Yeah, you have my permission.
Can you please tell me your name and how old you are?
Ikuya Mansan, 47 years old.
Okay, please, why have you come to see the doctor today?
I have these severe headaches.
Okay, for how long?
For the past 2 days.
2 days?
Yes, 2 days.
Okay, can you please tell me more about this headache?
I was there for I think 2 days ago when I realized that my head was paining me so much. I have not experienced that before.
Okay, so can you tell me the side of your head which it occurred and then how it occurred and also how it felt like?
It occurred on my forehead and also at the back of my forehead. It just came, and then it was very severe, like I said.
Okay. Did it come as a result of something? Did something triggered it or
No,
it just came?
it just came.
Did you do something about it did you do something about it when you started experiencing the pain?
Yeah, I got paracetamol, but it was not going down.
Okay. Okay, so I want to know if it feels like a band, like.
No.
Okay. Is it throbbing? Like, is it throbbing like somebody is choking you? Piercing you with knife, throbbing?
No, it's not throbbing, but it's so severe. It's very sharp.
Okay. Is it one side of the head?
It's my forehead and my back, not one side.
Your forehead and your back. Okay. Do you have any okay, yes. Do you have any do you feel dizzy?
No.
How about vomiting?
No.
Okay. I would like to know if you have fever.
No.
You don't feel sick? I mean, do you feel unwell?
No.
Okay. Do you feel difficult to breathe when you lie down flat on your back?
No.
Do you feel like do you wake up suddenly at night because you feel breathless?
No.
Okay. Do you cough?
No.
Do you have any chest pain?
No.
Have you noticed any changes in your bowel habits?
No.
Okay. Do you have any chronic medical condition I should know about?
Yeah, I have hypertension.
Okay. Please, have you been admitted to the hospital before?
No.
Sorry, the hypertension, for how long have you had?
For the past 5 years.
Okay. You've not been admitted to the hospital before?
No.
Have you received blood transfusion before?
No.
Okay. Are you on any medication for the hypertension?
Yes, I'm on amlodipine and then bendrofluazide.
Okay. Do you have allergies to any food or drug?
No, there are no allergies.
Okay. Please, I would like to know how many times you have been pregnant.
I've been pregnant twice.
Okay. So how many times have you given birth?
Twice.
Okay. I would also want to know the your cycle length, like your cycle length. Yes.
Oh, right now I am menopausal, but when I used to bleed, it was around 28 days.
Okay. How long ago have you been menopausal?
Oh, just 2 years ago.
Okay, please, I would like to know where you stay.
I stay at Taco.
Okay. Are you married or single?
I am married.
Please, do you have kids?
Yes, I have
Yes.
kids. I have 2.
Yes. Please, are you staying with your partner currently?
Staying with my husband.
Okay. I would like to know if you are on any health insurance.
Yes, I'm on health insurance.
Is it active?
It is active.
Okay. Are your parents still alive?
No, they are not alive.
Before that, I would like to know, do you take alcohol? Do you drink alcohol?
No.
Please, will you be kind enough to tell me if you take cigarettes? I mean, if you smoke cigarettes. Okay.
Don't.
You think your parents are alive?
They are not alive. Oh.
Okay. How many siblings do you have?
I have just one sibling.
Okay. Is he or she alive?
Yeah, she's a twin. I'm a twin, so she's alive. Yeah, she's alive.
Okay. Do you have any family history of chronic medical condition?
My dad had hypertension before he died.
Okay, thank you very much. I would like to know what your perceptions are about your condition.
Okay, time up. Can you please present your history? Summarize your history.
Okay, I present a 47-year
Only a
Ekiamasa.
summary. A summary.
Yes. I present a 47-year-old Ekiamasa who presented with a 2-day history of severe headache, and which was very severe and severe on the forehead and then the occiput area. It occurred suddenly. Systemic inquiry was unremarkable. She has a history of hypertension, and she's compliant with her medication, and she is married with
summary. All right, so what's your diagnosis?
Acute subarachnoidhemorrhage.
What's in your history suggested that?
She has a history of hypertension. And the fact that it occurred suddenly.
What else? What else should have suggested subarachnoid hemorrhage, which you didn't ask? You should have asked of the, although you asked of the character, she was saying that it was sharp. You should have asked whether it was the worst headache of her life, and if she felt it's like a tender clap. Okay, those terms have to come. You should have asked of seizures. You should have asked of loss of consciousness, whether there was loss of consciousness. Your ODQ, I saw that you were ruling out migraines by asking of vomiting, unilateral headaches, and all that. I heard you mention fever, probably thinking of meningitis, but I should have also thought of stroke. Okay, stroke, any associated weakness. So here, when you are starting with a systemic inquiry, you would have to focus on the neuro aspect very well. Ask a lot of questions there. If you had asked of seizures, you'd have gotten it. You'd have gotten it as part of your questions you asked. If you had asked of loss of consciousness, you'd have gotten it, because all these are. And then you should have asked how the pattern of the headache. Did it start and then suddenly peaked? You know, what was the progression? You know how acute how subarachnoid hemorrhage is like. You should have probably asked enough questions to rule out meningitis, apart from the fever. The fact that whether she's recent travel up north, is there any photophobia? All these have to come. Okay. You go ahead. What are your differentials apart from the subarachnoid hemorrhage? What are your differentials? Any differentials?
Yeah, my differentials, you've already mentioned the meningitis and then the tension headache, cluster headache, and also.
Are you sure? Are you sure you are likely to find a cluster headache in a female? Although it can happen, but would you mention that?
No, Doc.
You wouldn't mention that as part, because cluster headaches are usually male. The male predilection is, very high, and so the headaches, always try and ask if that's the first time it has occurred, because that is the paramount way of, although not an absolute way, the paramount way of differentiating between what primary headaches and secondary headaches, because you are telling me that the woman has a secondary headache. So if I had asked you that, what shows that it's a secondary headache, or this is the first time it has occurred, so it is not likely to be primary. And then among the secondary headaches, you are thinking of subarachnoidhemorrhage, because it was sudden in onset and then it peaked in intensity within seconds to minutes. And the fact that the site was occipital and a bit frontal, the fact that the patient described it as the worst headache of her life and she had a tender clap headache, the fact that I asked of seizures and then loss of consciousness, but there was nothing like that. And then you quickly chip in, do you have fever? Do you have difficulty looking at light? Have you traveled to the north recently? Any seizures? You did well to ask of the band-like thing, because tension type headache is the most common form of headache, isn't it? So that is one of the first things you have to rule out. Tension type headache. Okay. How long do the headaches last? All these have to come in. You did very well in the past medical history. You forgot the surgical history. It's very important. You didn't ask of any surgeries. It's very important you do that. The systemic inquiry you should have spent some time on the neuro. So always get that principle that if someone presents with the respiratory symptom, you should really go through the respiratory system very well. If someone presents with a neurological symptom, you should be able to go through the neurological system very well. Okay. Also, what else? Yeah, so the drug and allergic history, well done. The social history. Stop asking partner. She says she's married, and so husband. When you use partner, it is not a right term to use. What else? What else do I have? What comment do I have? And when you are giving a summary of your history, please give a diagnostic, give the illness script. Give the illness script. The summary is supposed to diagnose the patient. The patient, whether she's married or not, doesn't diagnose her. Whether it doesn't diagnose her. So for this patient, if you are giving a summary, it should be the illness script. So in summary, I present a 48-year-old or 47-year-old woman who is known to have hypertension and compliant on amlodipine and then Bendro, presented with a 2-day history of a severe sudden headache. The severity you should have asked, it's part of the markings. You should have asked on a scale of, okay? You should always try and then ask those questions. Okay? So I present a 47-year-old woman known to have hypertension, compliant on the medications, who presented with a 2-day history of a sudden onset headache, which she described as the worst headache of her life. It was tender clapping in nature, and it was situated in her occiput and then in the forehead, or in her forehead. There was no history of fever, vomiting, but there's a history of maybe photophobia, because subarachnoidhemorrhage can also come with photophobia. You know that?
Yes, doctor.
They can also come with neck stiffness. So they can come with symptoms of meningism. Okay, so you have to take note of all those things. All right, good. So, but it was a good history taking overall. Yeah. So, what investigations will you do for her? Mention 2.
I'll do CT scan of the head.
I've told you can't just say CT scan. What's CT scan?
Sorry, computed tomography
No,
scan
a plain CT. We have two types of CT.
Okay,
plain CT scan. If you did the CT scan and it was, what are you looking for on the CT scan?
I'm looking for hyper density lesion because I'm suspecting a rupture of a vessel.
So you are looking for enhancement or hyperdense enhancement of the systems, the spaces in the spider pattern. Okay, that will show you that the patient has a subarachnoid hemorrhage. What if you say hyperdense lesion? Hyperdense lesion where it can be a hyperdense lesion that is what, an epidural hematoma, a subdural hematoma. It could be an intracerebral hemorrhage. All of those are hyperdense lesions. But where is it? It is lining the systems, in a spider form. That is what makes it subarachnoid hemorrhage. Okay, if you did the head CT and then you didn't find anything, what would be your next step? Assuming you did a plain head CT for this one, you didn't find anything, what would be your next step?
I'll do lumbar puncture.
What are the lumbar puncture findings of subarachnoid hemorrhage? What are the CSF findings of subarachnoid hemorrhage?
There will be yellowish discoloration of the CSF, cerebrospinal fluid.
What is that called? What is the term given to that yellowish discoloration? Have you heard of xanthochromia before?
Yes.
That is xanthochromia. What else do you find on CSF?
The protein levels will be normal. The opening pressure will be high.
The opening pressure will be high, but that's very good. But what will happen to the protein level?
Okay, it will be high.
It will be high. It will not be normal. Yeah. You have blood in the CSF. Blood contains hemoglobin, isn't it? Hemoglobin is a protein.
Yes.
Yeah, so you have a high CSF. So you use the MOCPAC microbiology, you not find anything. Opening pressure will be high. What is the normal opening pressure of the CSF?
5 to 20 centimeter of water.
Although centimeter of water, although some books say 10 to 20, isn't it? So 5 to 20 centimeters of water. So it will be above that. So if you have a manometer, you check that. And then G, glucose. There is no organism, so you don't expect glucose to change, isn't it?
Yes.
P for proteins. There's a lot of blood there, so the proteins will be high. And then A for appearance. You have a xanthochromic sample, isn't it? Then C for cell type. You didn't expect to find any neutrophils or lymphocytes, but you are expected to find some blood cells in there. Okay.
Yes.
Good. What other investigation would you do apart from what other ancillary investigations would you do apart from the CT scan, and if normal lumbar puncture? What other thing would you do? Sorry.
Full blood count.
What other thing would you do? What other important? Yes. What other? I heard the full blood count, but I'm still on it. What other important investigation would you order for?
I would also. I would also do blood culture and sensitivity.
Why?
I want to. Supposing I didn't know the diagnosis, I would like to rule out.
No, this patient has subarachnoid hemorrhage, which you mentioned. On point, your first answer is correct. So, why did you do the plain head CT? It was because you're looking for subarachnoid hemorrhage. You didn't find it, and so you went ahead to the lumbar puncture within 6 hours. Now, I'm saying that, still regarding this diagnosis, what other investigation would you
do? An MRI.
MRI of what?
Of the head.
No. What other investigation would you do? Wouldn't you like to find out if the supposed Berry's aneurysm is from someone? A supposedly ruptured Berry's aneurysm. If you are thinking that the patient has Berry's aneurysm, what else would you do?
The angiography.
Okay, you may do a cerebral angiography, but what else do you do? Where is the Berry's aneurysm from? What are you interested in? What are you interested in? What is the... Let me stop giving you clues. Think about it. What are you interested in again?
If there is Berry's aneurysm, there's the likelihood of it getting ruptured, so stroke can also occur.
Wouldn't you want to find out where the Berry's aneurysm is from? Which condition is which condition can give you Berry's aneurysm and hypertension that the Berry's aneurysm can rupture?
Polycystic kidney
Yes.
disease.
So what would you like to do?
Okay, I'd like to do blood urea electrolyte and creatinine.
Be careful.
Abdominal ultrasound.
Abdominal ultrasound. Abdominal ultrasound. Abdominal imaging. Okay, and then the renal function test, like you said. Okay, so the blood culture and then the full blood count, not really necessary. Yes, the cerebral and angiography may be necessary. All right, so how would you manage this patient?
It's an acute condition, so I would admit the patient, and then...
It's an emergency, not an acute condition. It's an emergency.
It's an emergency, so I will cancel and admit the patient, and then I would do a quick primary survey assessing and appropriately managing the airway, breathing, and circulation. Then I would secure IV access and take sample for investigations like full blood count, grouping, and cross matching. Then I would like to start fluid and electrolyte therapy.
Be careful. This patient is probably hypertensive. She's not dehydrated. She doesn't have any imbalance. So why do you want to do that? Where would you admit this patient to?
The intensive care unit.
Yes. Ideally, this patient has to be in the intensive care unit. What would you ensure in the intensive care unit environment?
I would
you'd ensure that it is what? A dark place, because they can have photophobia. Right?
Okay,
it's a dark place. What else?
I'd also ensure that it's not there's no noise around.
Yes. That's why it's very important to be asking of the photophobia and then the phonophobia. So you ensure that you admit the patient to the ICU. It should be a dark place, and then it should be a quiet place, because the light and then the noise exacerbates their headaches. What else would you do?
Okay. Doc, I'll give IV analgesia.
No, but apart from that, what else would you do? What else would you do to decrease the intracranial pressure, which is contributing to the headache? You elevate the head of the bed.
Okay.
Okay, so all these are non-pharmacological. So you admit the patient to the ICU. I hope you are listening, because I'm teaching you subarachnoidhemorrhage. I may not teach it again.
Yes.
I hope you are making notes. So you you admit the patient to the ICU, ensure that the environment is quiet, the environment is dark, not jittery. You elevate the head of the bed to what? 30 degrees, so that you can non-pharmacologically decrease the raised intracranial pressure. What else would you like to do? You may have to give laxatives, okay, to prevent constipation, because when they are constipated, they can have headaches, isn't it? Once they are constipated, they'll be straining, and then when they straining would cause, it's a Valsalva maneuver, and so that will cause headaches, because you know that the headaches of raised intracranial pressure are associated with what? Valsalva maneuver. So anything that will make the headache worse, like straining during defecation, coughing, all of these can worsen the headache. So if you want to give some anti-cough because they are coughing, you only give when they are coughing, you give it. Then you give maybe lactulose, a
Okay,
laxative to prevent, to manage the headache. Then what drug would you give? What is the drug of choice for subarachnoid hemorrhage and why is it given? Of course, you give your IV analgesia, I agree. What is the drug of choice? What drug do we give in subarachnoid hemorrhage? Have you heard of, where is your face? Hello?
my network jumped.
Your network jump, okay. Have you heard of nimodipine before?
No, Doc.
Oh, you've not heard of it before. So please take note of that, okay? Nimodipine. 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 So nimodipine, what do you think about it? Is it an antihypertensive? Of course, when you hear the dipine there, it looks like a calcium channel blocker, isn't it? It's in fact a calcium channel blocker. Okay, it is a dihydropyridine calcium channel blocker, but it doesn't function as an antihypertensive. Although it sounds like felodipine, amlodipine, nifedipine, we give nimodipine, but nimodipine doesn't function as an antihypertensive. When you give nimodipine to a patient with subarachnoid hemorrhage, what you are doing is that you are preventing vascular spasms, because the nimodipine will go and then block the calcium channels in the muscles, okay, of the cerebral vessels, and so they can't contract. Are you following?
Yes, Doc.
Yes. So you see, when the vessels in the head contract, what do you think can be a complication?
If it contracts, it would increase the blood pressure.
Are you sure? It will cause an ischemic stroke. When the blood vessels in the brain the brain start contracting, you know, the blood vessels, they lie within the subarachnoid space, isn't it?
Yes, Doc.
If you remember the anatomy lecture we had, the blood vessels, every structure which is moving into the brain and out of the brain would eventually have to pass through the subarachnoid space, isn't it?
Yes.
So if you have blood in the subarachnoid space, what do you think the blood will be doing? It will be irritating the blood vessels there. And that may be causing what? Vasospasms. And if you don't do something about it, because of the spasms, there is no atherosclerosis inside, but the spasms will cause an ischemia, and if that ischemia is not taken care of, would lead to an ischemic stroke. So it is possible for someone with subarachnoid hemorrhage to have an ischemic stroke. And so we give nimodipine not as an antihypertensive. So if they come and their blood pressure is high, you treat their blood pressure. Because remember that it is a hypertensive emergency if the blood pressure is more than what? 180, more than or equal to 180, 120. That one, you have to crash the BP with your antihypertensives, IV antihypertensives, like you know, and then put them on their amlodipine or their baseline antihypertensive. But don't say that, oh, the patient's on amlodipine, why do I want to give another nimodipine? No, the nimodipine there is not an antihypertensive. It is there to prevent vasospasm, which might lead to a ischemic stroke as a complication, a vasospastic stroke as a complication. Do you understand? So the management of subarachnoid hemorrhage, it is a medical emergency, and in fact, if the blood pressure is more than or equal to 180 or 120, it is a medical emergency as well as a hypertensive emergency. And so you counsel and admit the patient, you call for help and assign rules, then you quick primary survey and appropriately manage airway, breathing, and then circulation. Then you admit the patient to the ICU, and if the blood pressure is more than 180, 120, you give IV antihypertensives to what? Bring it down. That is after the diagnosis. Okay, you bring it down after your CT scan. You bring it down. I'm sorry about that. You bring it down. Then after that, what you want to do is, while in the ICU, ensure that the place is quiet, the place is dark, and then you elevate the patient's head end of the bed to what? 30 degrees. You put the patient back on her antihypertensives, and then what do you do next? You give medications which will prevent constipation and then manage cough if the patient is coughing. All right. And then the next thing to do is to give your nimodipine. The nimodipine is 60 milligrams. I don't think you have to know the dose. 60 milligrams 4 hourly for 21 days or 3 weeks. For 21 days, okay? Then you have to, yes, I think that's about it. Okay?
Okay.
All right.
Okay.
Well done.
Thank you.
Let's go to the next station. So the next station is a diagnostic station.
Okay.
Yeah, describe what you see.
Okay. This is a plain CT scan of the abdomen showing multiple hypodense lesions of the 2 kidneys.
Okay.
Yeah.
All right.
And
so
the kidney enlarged.
Kidneys are enlarged. Okay. So what is your diagnosis?
Polycystic kidney disease.
Is that what you say? What is the how can you better put it? Autosomal dominant. Okay, because you know that we have 2 types. You have autosomal recessive. They wouldn't grow up to this point. They usually don't grow up to this point. Autosomal dominant polycystic kidney disease, isn't it?
Yes.
All right. How would this patient present?
I think they will present with abdominal distension.
Are you sure?
They will present with bilateral flank pain too. And
they may present with bilateral flank pain. Okay, what else?
Okay, they may also present with
there may be hematuria, okay, and they may present with hypertension, secondary hypertension. Okay, on examination, you find a secondary hypertension. You find that they have what? Severe headaches. All right.
Okay.
Yes. So what associated anomalies can you think of if a patient like this came? What other associated anomalies? Yeah.
Berry's aneurysm.
Berry's aneurysm. What else? Hepatic cysts. Okay, hepatic cyst is part. Sometimes mitral valve prolapse. Okay.
Okay.
All right. Okay. Next station. So for a patient like this, what you do is what you manage the hypertension. Okay, and then you manage other risk factors.
Okay.
And then if the hypertension is poorly controlled, despite your conventional management, you refer the patient to a nephrologist, isn't it? All right. Look up your last station. Yes. Look at this ECG and then describe it.
Okay. A standard 12-lead ECG with a sinus irregular rhythm.
Are you sure? Are you sure it's a sinus rhythm?
Okay, it's non-sinus irregularly irregular rhythm and a rate of, please hold on. This math is going to be hard. I think with a rate of I hope I can use calculator.
Why do you want to say a calculator? Calculate the rate and.
I want to calculate the rate.
But why do you want to say a calculator?
Okay.
Irregular rhythm rate is even the easiest to calculate.
Yes, and with a rate of 90 beats per minute.
So there's a standard 12 lead ECG.
Let me finish.
What?
Yes, so I want to finish the description.
Okay. All right.
Yes, with a rate of 90 beats per minute and an absent P wave, and then I think yes, an absent P wave, yes, and then irregular spaced QRS complex.
Okay. Can you say something about the rhythm, the axis?
Yes, the axis.
Can you see or?
It's yes, I can see. I think the axis is normal.
Okay, I agree. What is your diagnosis?
Atrial fibrillation.
Any other differential diagnosis?
Atrial flutter.
Hey.
Okay.
What would you find on ECG that will show that there is atrial flutter? Sawtooth waves. This one there are no sawtooth waves. What else? What are the differential diagnoses for irregular rhythm? Atrial flutter with barring blocks. It means that the blocks are not constant. So it will block 2, it will block 1, it will block 3. You see it. So the one that it blocks 2, the one that it blocks 3, the one that it blocks 1, you see that there will be what? Irregular rhythm. Do you get it? Atrial flutter with barring blocks. And then multiple ectopic beats. I thought I've taught you this already.
Yes, Doc.
Multiple ectopic beats.
I couldn't listen to them.
All right. What did you find on examination for this patient? What findings would you find on examination that will suggest your atrial fibrillation?
The irregular pulse, and then the pulse deficit will be more than 10.
Okay.
Also, yes, the patient will be maybe having respiratory distress.
All right, that is fine. So how would you differentiate atrial fibrillation on examination? How would you differentiate atrial fibrillation from the others, like ventricular ectopics? All of them will give you irregular pulse, but how can you differentiate them on examination?
I think you'd ask the patient to involve in an exercise, and after that, with the others, the irregular rhythms would disappear.
Will temporarily resolve, but atrial fibrillation will continue, isn't it?
Yes.
Isn't it? What else? How else can you do that?
Yes.
You use the pulse deficit. Okay, so the others will have a pulse deficit less than 10. Atrial fibrillation will have more than 10. That is why when you do the irregular pulse, you have to go ahead and do the pulse deficit. Do you understand?
Yes.
What are the types of atrial fibrillations you know?
We have the first detected atrial fibrillation, the paroxysmal atrial fibrillation, the persistent atrial fibrillation, the long-standing persistent atrial fibrillation, and then the permanent atrial fibrillation.
What is the difference between paroxysmal atrial fibrillation and then persistent atrial fibrillation?
With the paroxysmal atrial fibrillation, it occurred within the occurrence or the symptoms started within less than 7 days, but with the persistent, it's occurred and extended for more than 7 days.
What else? So the paroxysmal, the symptoms usually start and last for less than 7 days, isn't it?
Yes.
And then it can spontaneously go away. But the persistent lasts more than 7 days. It can spontaneously go away, or you have to intervene. Isn't it? All right.
Yes, sir.
Okay. So what is the most feared complication for atrial fibrillation?
Ischemic stroke.
Okay. Which form? Is it the thrombotic or the embolic one?
Embolic
one. Okay. How would you manage a patient with atrial fibrillation?
Okay, so I would admit the patient.
You won't admit the patient. You won't. Okay, so, don't admit all patients.
Okay.
What are the principles? Just tell me. What are the principles?
Principle is to anticoagulate.
Hey. Okay. That's not what you start.
True. There's rhythm control, there's rate control, and then yes, I think the last one is the anticoagulation.
Start again. I missed your first answer. What is your first answer?
Rate control, rhythm control, and then the anticoagulation.
Okay, so that is very correct. So the first one is what? To reverse any underlying cause, isn't it? Or to treat any underlying cause. So you don't just control the rates. If the underlying cause is hyperthyroidism, you have to give antithyroid drugs. If the underlying cause you think it is pneumonia, you have to do something about it. Okay, so treat any reversible underlying cause, then rate control, there is rhythm control, then there is anticoagulation. All right. How would you determine whether a patient needs a long-term anticoagulation or not?
By doing the Chadva score. So if it's above 3, then the patient will need a long term.
I'm not sure I taught you that. How did I treat Chadva score? What is the interpretation? If it is 0, the patient doesn't need any anticoagulation.
Yes.
Okay. So actually we have valvular associated atrial fibrillation and a non-valvular, isn't it? When I say valvular, I mean a patient with a prostatic valve inside, isn't it? A patient with a rheumatic valvular disease. Then we have atrial fibrillations which didn't come from valvular disease, like the hyperthyroidism, the polycontrolled hypertension, coronary artery disease, the myocarditis, myocardial infarction, pericarditis, alcohol, pneumonia, COPD. Do you get it? We have valvular and non-valvular. For the like a patient with a prostatic valve, the patient has to be on anticoagulation, because the fact that there is a prostatic valve inside makes the patient at risk of forming clots. So for that patient, you know that the anticoagulation they have to be on is warfarin. It's warfarin. So the patient with rheumatic valvular disease, the patient with prostatic valves, warfarin. Then we have the non-valvular ones. The non-valvular ones, that is the one you use the Chadva score. If the patient has a score of 0, you don't have to anticoagulate. The patient has a score of 1. Then that one, there is a controversy. Some people say you can anticoagulate with the direct acting anticoagulants like the factor 10 inhibitors like rivaroxaban, or you can give aspirin. So when you read Oxford, you see aspirin or rivaroxaban. Okay, even Medscape up to date, you see aspirin but if it is 2 or more, then the patient needs anticoagulation with 2 or more, not 3. Okay, 2 or more, the patient needs it. So what drugs can you use for the rate control? Mention 2, then we'll end your exam.
You can use calcium channel blockers like the.
Is that the first you use?
The beta blockers.
Yes, beta blockers, and then some calcium channel blockers like
the verapamil.
And what else? What other calcium channel blocker do you know?
Diltiazem.
So you see, those ones, they are not really used in Ghana. So when you go and mention calcium channel blockers, I've told you my story. I met the same question and they asked me, what drug would you use for rate control? Then I just remembered Oxford, the page in Oxford, which mentioned the non-dihydropyridine calcium channel blockers like diltiazem and verapamil. But apparently nobody uses that. The beta blockers here, I mean, it's not like nobody uses that, but it's not so common in Ghana, not commonly used. So they got upset a bit, although it is in books, okay? So the beta blockers like the esmolol and then the rest, calcium, if beta blockers are not there, then you can think of the non-dihydropyridine calcium channel blockers like the verapamil and then the diltiazem. And then if the patient has an associated heart failure, which one do you think would be best?
The cardio-selective beta blockers.
The digoxin. I thought you were not here when I was teaching the new atrial fibrillation. I want you to look at it again.
Yes.
But you felt that the first one you've had is enough. I said a lot of things in there. I said a lot of things in there. Go and have a look at it. All right. Have a good day.
Thank you.